All right, Mr. Patrick. So to cover everything that we've gone through today, looks like we're dealing with some right leg pain. Comes from the hip down to the buttocks, goes to right leg, right calf, across the outside of the foot. Don't really know where it came from. Just kind of showed up out of nowhere during one of your walks. Happened around a month ago, or started around a month ago, and it's also. You hadn't said this, but there's some associated low back pain. A lot of the range of motions and stuff that we've done would indicate that there'd be low back pain with it. So, I mean, just like the pertinent exam findings is kind of what I would call it, but it's, we did the test where we had you kind of push into your low back, and that recreated the symptoms. Doing a reverse lunge in the cobra position also kind of were difficult or painful, along with some other postural things that we looked at. So I wanted to kind of focus and tackle the situation of you too. So the largest concern or fear that you had was that you had some x-rays before that showed some degeneration and some other findings that we'll discuss in a little bit, but you are worried that this pain is going to always be there and it's going to get worse and it's just never going to be relieved, which is I guess a good concern, and hopefully it's something we can tackle. Now we're going to talk about the stress that these concerns are giving you, and then we'll get to the situation in a bit. But the stress that it's putting on your life is something that we also want to get rid of. Stress has been shown to negatively affect pain thresholds and treatment recovery time. So I have some stuff we can go through that's going to decrease stress. I guess our first one would be the fact that what we're dealing with for you is, or what we're calling it, will be foraminal stenosis. You have intervertebral foramina, which kind of are the canals where your nerves exit between your vertebrae of your spine. And some of those x-rays have shown that you've had facet and ligament hypertrophy, remember? And I think that that's a contributing factor to this, because it's even in the same area, the L4 through S1, which is the base of your low back. That's where those hypertrophies are located, but that also coincides with the referral pattern of the pain. So it's also where you're kind of feeling the pain is where those nerves are exiting. So I have a message from Dr. Seungwoo Han, MD. Most cases of neuroforaminal stenosis improve on their own or with conservative at-home treatments, like painkillers, gentle yoga, and PT, physical therapy. And that's what we're going to be focusing on. I would like you to just kind of take that information in, understand that if this is what we're dealing with and this is what it is, we can kind of decrease our stress, because we know that most cases, and yours should kind of follow suit, will resolve. So that you're not going to have this pain forever, and you're not going to always be in pain with unrelieved. So now that we've tackled the biopsychosocial factor of it, I have 2 exercises. Well, actually, I have one exercise that I'm going to show you, but the other exercise is that I would actually like you to continue bicycling with your trainer. I know y'all switched from walking to bicycling, and what works with stenosis is bicycling. It's flexion-based exercises because of hypertrophy and extension, so we're going to be focusing on tightening your muscles and letting that hypertrophy kind of stretch out, not let it be so thick and clogging up the foramina. So bicycling will actually be important. I know you've been going to your trainer 2 to 3 times a week. Continue that. Explain to your trainer how the bicycling should keep being utilized, and it's therapeutic for the stenosis and the conditions. And then I guess for external cueing for that one. Just if you're in pain at all, the external cueing for bicycling is just continue working out. And if you feel any pain at all in the low back, adjust your posture. Adjust your seating adjust how far you're up on the seat, adjust how far you're up on the pedals, just move on there. And then you can even decrease if you need to. And even walking, I know the exercise number 1 is bicycling, but if you want to still walk a little bit. Whenever you start feeling the pain, rest, sit forward, get up, and you can walk the rest. And then the second exercise that we'll be giving you will be part of a Williams flexion exercise. It's single knee to chest with posterior pelvic tilt. We're going to be doing 3 sets of 15 reps for 10-second holds, twice daily. So that looks like this. You're going to be laying on your back, knees bent, and what the posterior pelvic tilt is imagine I have a hand on my low back, and I'm going to move my rotate my pelvis to crush that hand, to push that hand into the floor, push your low back into the floor. That'll be the posterior pelvic tilt portion. What you're going to do is posterior pelvic tilt, take a knee, bring it up, holding the tilt, and you're going to hold this knee here for 10 seconds. Drop, release tilt, and then tilt again and use the opposite leg for another 10 seconds. Okay? And then drop tilt. We're going to be doing those again, like I said, 3 sets, 15 reps, 10-second holds, twice daily. And if there's any more questions or concerns, just let me know.